Services Committee meeting for Tuesday, March 16th, 2021. We are in the State House Lounge. We have members here present with us as well as online. Clerk, will you please take the roll?
Yes, Chairman. Chairman Casey.
Here.
Representative McLaughlin. Representative Donovan. Here. Representative Ackerman. Here. Representative Azzanaro.
Here.
Representative Bennett.
Here.
Representative Bia.
Here.
Representative Kasar. Here. Representative Giraldo. Representative Fogerty. Here. We didn't forget you. Representative Handy. Representative Morgan. Representative Potter. Representative Roberts.
Present.
Representative Morgan. Okay. Representative Speakman.
Present.
Okay. Chairman, we have a quorum.
Thank you, Clerk. This evening, we have 18 items on the bill, 18 items on the agenda, and I am going to take the agenda out of order to accommodate some folks that need to travel. First, we are going to have Representative Lombardi. First, if I can accept a motion to hold the bills on the agenda for further study from Representative Ackerman, motion. Second, from Representative Fogerty. I need to take a roll call vote for that. Please stand by.
Okay. Chairman Casey.
Yes.
Representative McLaughlin. Representative Donovan. Yes. Representative Ackerman. Yes. Representative Azzanaro.
Yes.
Representative Bennett.
Yes.
Representative Bia.
Yes.
Representative Kasar.
Yes.
Representative Fogerty.
Yes.
Representative Giraldo.
Yes.
Representative Handy. Representative Morgan.
Yes.
Representative Potter. Representative Roberts.
Yes.
Representative Speakman.
Yes.
Okay, Chairman. 1, 2. Okay, that's 12 to 0.
Thank you. All bills will be held for further study. And now I'm going to move on to Representative John Lombardi for House Bill 5804. Representative Lombardi, if you would introduce your bill.
Sure. Thank you, Mr. Chairman and members of the committee. I appreciate it. Thank you. So it's 5804 relating to state affairs and government, housing resources, homeless shelters. And what this act would do, Mr. Chairman and members of the committee, very simply, would create a commission to establish homeless shelter standards for regulations. Currently, in my understanding, there's no policies and procedures. Certainly with COVID, these are shelters have been probably exacerbated, and obviously it affects the less affluent communities, minorities, single parents, and what it would do, at least create some dignity and some understanding as to what's happening when families are forced into this situation. Certainly no through choice of their own, but because of, again, a pandemic or, whatever it may be. And with that, Mr. Chairman, I want to thank you for affording me this opportunity, and I will endeavor to answer questions if I can. Thank you.
Thank you, Representative Lombardi. Are there any questions from the committee regarding Representative Lombardi's bill? Representative Kasar, go ahead.
Yeah, more a comment than a question. I think this is a great starting point, and I think that we could benefit from seeing this happen. Like Rep. Lombardi said, the COVID really exacerbated problems, but things were a little tight before, and we could use to make sure that the homeless in our state are kind of addressed with dignity. Yeah, thank you.
Thank you. Are there any other comments or questions from the committee at this time? Okay, thank you, Representative Lombardi.
Thank you, Mr. Chairman. I appreciate it. Thank you.
Okay, we're going to close the hearing on House Bill 5804. We are going to move on. It's going to be Representative Tom Noret. Representative Noret has a bill 5611 relating to business and professions and pharmacy prescriptions. Representative Noret, welcome to the committee. You have the floor. Go right ahead.
Chairman Casey, thank you.
And esteemed colleagues, thank you very much for hearing this bill this evening, 5611. The act would require pharmacies to notify their customers whether their cost-sharing benefit exceeds the actual retail price of the prescription sought in the absence of prescription drug coverage. It would also prevent medical insurance companies and pharmacy benefit managers from penalizing a pharmacy for informing their prescription purchaser of alternate substitute drugs that are less expensive than those sought. It's pretty simple. It's a cost-saving benefit for anybody that would go into a pharmacy to purchase a prescription. Thank you.
Thank you, Representative Noret. Are there any questions at this time from the committee before we get to testimony, please? I'm sorry, Representative Morgan.
Thank you, Chairman. Representative Noret, can you just give me a little bit more information about, I didn't realize that we could pay more if we have drug coverage than if we don't. Is that what you're saying here?
It actually is true. So you could go to a pharmacy and say, pick up a prescription. If you don't ask the pharmacy how much that prescription would cost you without using your health coverage, it in fact could cost less than when you're using your health coverage. So again, I go to CVS or Walgreens to pick up a prescription. I'll always say, how much would that cost without my prescription coverage? And sometimes it's actually only $1 or $2 more if I were to purchase it with my coverage. I have only ever found it once to be less, but it could actually be less.
Are these like the highest priced prescriptions, or they just, can you give me some ideas of which ones?
I'm not a pharmacist, so I can't give you any ideas of which ones. I just know what I've gone to the pharmacy in the past to pick up for myself, my wife, my family. Whenever I've asked, I always make it a point to ask because I do know this information. And again, you can also, so the pharmacy now presently doesn't have to tell you that, hey, there's a generic drug that you could use and you could save money on this if you were to go with this, because of contracts that exist. This bill would eliminate the contract from being signed and forcing them to not tell you that. So again, could potentially be a cost savings for everybody. In fact, I can see Representative Fogerty's probably chomping at the bit. She knows probably a lot about this, but
Okay.
AARP is going to testify more on this, on the information of this bill, but I'm here to answer any questions that I can. But again, I'm not a pharmacist, so I couldn't tell you exactly what prescriptions would be
Okay.
cheaper.
Thank you very much. Thank you, Chairman.
Thank you. Representative Fogerty, go right ahead.
I would just say that this would not be on any of the bigger price targets. This is mostly for generic. So if you have in your contract that they've negotiated that your, third level copay is say like $20 and you can get the generic for, $10. They're gonna charge you for your $20 price. It's just what's happened. So he's right, that you could go in. Again, this is gonna be more or less on the generic products, not your brand name, first line, higher tier products. So it can happen, and you should ask. You definitely should ask.
Okay.
Thank you, Representative
I
Fogerty.
learned something.
We have Representative Mia Ackerman, please.
Thank you. I always thought that the most of the big healthcare plans automatically give you the generic over the name brand anyway for their cost savings.
So some do, but if your doctor, and again, not a doctor, not a pharmacist, my dad was a pharmacist, but not a pharmacist, if your doctor recommends for you or calls in the name brand drug, then that's what they're going to give you, is the name brand drug if the doctor specifies that that's what they want for you. So
It
again,
has to be written on the prescription, no substitution for a brand name product.
Say-
Most doctors won't do that. There's a box at the bottom that a doctor would have to sign for a substitution.
correct.
So you would get so if they write brand name, they're going to substitute. And if you want to keep the brand name, you're going to have to write no substitution on the script.
Right.
Yeah.
So,
they
again,
will- They
I
will
know-
try to go with the generic.
Right, so I know my wife has had issues with some generic drugs, but again, they don't have to tell you if there's a sort of less expensive substitute presently, and that's what this bill would just fix.
Thank you for the question, Rep. Ackerman. Representative Speakman, go right ahead, please.
Thank you, Chairman. Representative Noret, can you help me understand, does this bill do two separate things?
My understanding, it does.
Okay, so if my insurance will pay $15 for my prescription, but if I bought it without insurance, it would cost $10, that's one thing. And then the other thing
Yes.
is that the pharmacist has to make available to you information about generic as opposed to brand name, right?
Yes, it does. Thank you.
Two separate things, okay.
Two separate things.
Thank you.
Correct. No, thank you. Good question.
Thank you. Before we go to testimony, we have Rep. Kasar with a question, please.
Thank you for introducing this bill.
Thank you.
It's going to be really helpful. Can you talk a little bit about the penalty piece, so that the pharmacist is at risk of a penalty?
I don't see a penalty in here, so I
You
couldn't.
mentioned it in your description, so I wasn't sure.
So I will tell you what I read for the description.
Okay, thank you.
You're welcome. This would require pharmacists to notify their customers when their cost benefits exceed the actual retail price of the prescription sought in the absence of prescription drug coverage. It would also prevent medical insurance companies and pharmacy benefit managers from penalizing a pharmacy for informing their prescription purchases of substitute drugs that are less expensive. So again, there is no...
Do we know anything about the...
I don't know anything about a
Okay.
penalty, nothing described in this about the penalty. I'm sure in this chapter, there may be a penalty that would go in the chapter of 5-19. There's probably a penalty section.
Okay, thank you.
I do not know the penalty,
Thank
sorry.
you. Thank you, Representative Kasar. Once again, Representative Speakman.
Thank you, Chairman. One more question about the first piece of this. So is it often the case that those of us with insurance pay more for medical services than those of us without in order to sort of subsidize those who can't afford or have bad insurance? And I'm just concerned, I don't know, again, I'm not familiar with the mechanics of it, but might it be the case that if those of us with insurance start paying the uninsured lower fee, that might create problems for the uninsured? You follow?
I follow, but be honest with you, I'm not going to take a stab at that hypothetical. That's way beyond the scope of my knowledge regarding pharmacy costs and medical insurance costs, so,
Thank you, thanks.
sorry.
Yeah, I think this is really focused on the consumer cost. And I have had, just if I may add briefly, I have had constituents call me and say that, they've run into the situation where they were going to pay $10 for a copay for their prescription, but they asked the pharmacist if there was an available similar drug or generic, and there was, and they paid only $5 for the generic rather than paying $10 for their copay. So we're talking about a cost savings from the end user. So that's the perspective we have. Are there any other questions? Representative Fogerty, go ahead.
Just one addition is that I don't think that the pharmacists, the pharmacies are trying to, rip people off. I think it's just a matter that they do such volume and that they push it out, and that's just where the patient's copay comes up on the system, and that's, sometimes they just get too busy to say, unless you get somebody who's really paying attention to that and trying to help the patient out. Again, it's all based on just insurances.
Correct. I don't think this
I
is an
agree.
issue with the pharmacists themselves taking advantage of anybody. It's basically, when I go to get a prescription, I expect to pay $10 every time. That's my prescription copay. I rarely would ask, what would be my cost without my insurance. Representative Morgan, please.
Thank you, Chairman. The only thing that I see as a difficulty here is when I go to pick up a prescription, they're usually in bins, and one of the assistants is going and getting it and bringing it and just ringing it through, so you're not really talking to the pharmacist or someone who would know if there's an alternative. So I think it gets a little tricky for the drugstores. I mean, I guess it's not insurmountable, but I don't always talk to the
Right.
to the pharmacist. Do you?
My understanding would be when a prescription is called in, let's say your doctor orders the prescription, so you're removed from the equation. You still have the ability to call, let's say, for example, a CVS. You have the ability to call CVS and ask to speak with the pharmacist, and say, there's an order for me, can you please check it? And at that point, you would be able to talk to them and ask them if there is a generic that would be less than the cost of whatever your prescription copay would be.
Yep, but does this say that proactively the pharmacists have to tell you?
My understanding of the bill, the way it's written, is that they must notify you that there's another option.
So, yeah, so they shall inform
Is that correct,
you. So
Representative
I
Noret?
guess there's that manpower issue. You don't always talk to a pharmacist. Sometimes it's just one of the pharmacist aides or something that actually bring out, they just bring out a bag. They don't even know what's in it.
Right.
Chairman, if I may?
Yes. Representative Noret, go ahead.
So first line of the bill, and again, this is already existing legislation, pharmacists, when dispensing a prescription, shall, right? That's the first part of the bill that's here, under 5-19.1-19. So I think there's a shall, and I would venture to guess that the person that's working, the pharmacy tech that is working under the pharmacist license that is on duty. So I would think that using the word pharmacist means that anybody that's working under that person's license presently, whether it's going to be the tech that has to answer the question, because if you ask the tech the question, they can give you the answer, is probably, it's under the umbrella, I would assume, right? And again, assume that's why it's just the word pharmacist, not pharmacist, pharmacy tech, employee. They're putting it is a more of a straightforward term. Yeah. Again, my assumption.
No, I honestly, I think this is a good idea. I just think the logistics of it become a little bit difficult for a pharmacy.
Understood. I don't, our job is not to map out
What they're gonna do.
how they process and how they proceed with the laws that we enact.
Yeah.
They just need to come up with that
Some
specific
idea.
procedure.
Sure.
Yeah. Okay, if we have no other questions, I'm going to move on to the verbal testimony.
Thank you.
Hello, Mr. Neto.
Yes,
This is Representative Casey from the House Health and Human Services Committee. How are you this evening?
I am great, thank you. How are you doing, Chairman Casey?
Good, sir. We have you testifying on House Bill 5611 by Representative Noret. If you would go right ahead, announce who you are representing, and go ahead with your testimony.
Thank you very much. My name is Matthew Netto. I'm the Associate State Director of AARP Rhode Island, and I'd like to thank you for giving me the opportunity to testify today on the House bill. On behalf of AARP Rhode Island, our 132,000 members in Rhode Island, we are in strong support of this legislation that would provide pharmacists shall disclose lesser priced drug substitutions, as well as inform the consumer when their cost-sharing benefits exceed the actual retail price of the prescriptions sought in absence of prescription drug coverage. Older Rhode Islanders are struggling with rising prescription drug prices and cannot afford to wait any longer. Year after year, they have seen prices increase by double digits with no end in sight. That is why 72% of older Americans say that they are concerned about the cost of their medications, making it a priority for policymakers to act on prescription drug prices. In 2017, the average annual cost for one brand name medication used on a chronic basis was almost $6,800. For the average older American taking 4.5 prescription drugs per month, the average annual cost of that therapy would be more than $30,000. As well, a recent study in the Journal of American Medical Association found that approximately 1/3 of patients are overpaying for their prescriptions. This bill would help to reduce those overpayments by giving patients more information about the pricing options available to them when they purchase needed medications. AARP Rhode Island supports House Bill 5611 because it would let consumers know when generic drugs or lower cost alternatives are available that contain all the same active chemical ingredients of the same strength, quantity, and dosage as for name brand prescription drugs. Rhode Islanders deserve to know when they can safely save money on prescription drugs. We urge the committee to support this bill and work to pass other common sense legislation to lower prescription drug prices. thank you for the opportunity, and I'm willing to answer any questions that I can. I've been listening in.
Thank you, sir. Are there any questions from the committee for our witness? Okay, sir, we are all set. Thank you, Matthew, for your testimony. We are going to move on to our next bill. We appreciate your testimony. Thank you for being here. Okay, House Bill 5611, the hearing is closed. We're going to move on to Speaker Pro Tem Kennedy for House Bill 5194. This is an act relating to business and professions regarding the Nurse Licensure Compact. Representative Kennedy, you have the floor. Go right ahead.
Thank you very much, Mr. Chair and ladies and gentlemen of the committee. So 5194 came about when several of my colleagues and I attended a meeting of the Council of State Government a couple of years ago. At that time, we had the opportunity to see that a number of states were moving forward towards the adoption of what's known as the Enhanced Nursing Compact, which would, for all intents and purposes, enable nurses in the state of Rhode Island to have an enhanced and comprehensive version of the Nurse License Compact, which would enable them to have a multi-state license in order to serve as a nurse. Rhode Island was one of the original signatories to the Nurse Compact legislation. I think at its peak there were, I believe, 25 states that adopted that original Nurse License Compact. And over the years, there was a lot of thought put into this about going to an even more enhanced version of the original compact. The original compact was developed in the year 2000. I think former Representative Peter Lewis was the original sponsor. Peter was from Westerly. But by 2015, the general thought was, what can we do to get more states involved with this? So through that, they decided to streamline the process and create this enhanced nursing licensure compact, which was implemented in 2018. And at the present time, there are 34 states that are signatories to that, including Alabama, Arizona, Arkansas, Colorado, Delaware, Georgia, Florida, Idaho, Indiana, Iowa, Kansas, Kentucky, Louisiana, Maine, Maryland, Mississippi, Missouri, Montana, Nebraska, New Hampshire, New Jersey, New Mexico, North Carolina, North Dakota, Oklahoma, South Carolina, South Dakota, Tennessee, Texas, Utah, Virginia, West Virginia, Wisconsin, and Wyoming. And Rhode Island is one of the handful of states that were original members of the compact that have not yet joined this compact. The whole purpose behind this enhanced nurse compact is to try to continue to increase access to health care, reduce overall costs to insurance companies, hospitals, and individual patients, and to support the efficient and strong health care delivery system. For those states that have become members of this enhanced compact, what they have done is they've issued to nurses who apply for it the opportunity to get this license, which enables them, once their state joins, they can then issue a license that will allow that nurse to go to any of the other 34 states within the compact in order to provide nursing services. We all know in this past pandemic year how difficult it was to find nurses who would be willing to travel to other locations. In many cases, the nurses who are the healthcare professionals that were on the front line along with the doctors had a very, very difficult time within this pandemic as well. So this would provide a highly effective means for nurses who are needed somewhere other than the state that they're currently licensed to be able to travel there and not have to deal with any of the major issues of having to get an emergency license, because a license in one state serves as a license in another state. The commission that put together this nurse compact developed 11 uniform license requirements for this multi-state license. One was that it meets the requirement for licensure in their state of residency. that they have graduated from a board-approved education program, that, let's see, they passed the NCLEX RN or LCLEX-PN examination or a predecessor examination, that they're eligible for or hold an active unencumbered license, that they've submitted to state and federal fingerprint-based criminal background checks, that they have no state or federal felony convictions or misdemeanor convictions related to the practice of nursing, that they're not currently a participant in an alternative program, that they're required to self-disclose current participation in alternative programs, and that they have a valid U.S. Social Security number. The legislation itself, it's supported by the American Association of Colleges of Nurses, the American Association of Neuroscience Nurses, the American Association of Occupational Health Nurses, the American Association of Prison Control Centers, the Association of Camp Nurses, the Association of Vascular Access, Cross Country Healthcare Emergency Nurses Association, the Hospital Corporation of America, the National League for Nursing, National Military Family Association, Organizations for Associate Degree Nursing, Oncology Nursing Society, and Telehealth Leadership Council, as well as the U.S. Department of Commerce. This year in the budget, the governor submitted last week, one of the articles specifically looks at trying to get Rhode Island as part of this nurse compact, with the idea that this should help our state to move forward. What I want to make perfectly clear to you is the fact that you're going to hear from the nurses this afternoon that somehow this is anti-union, this is going to somehow have an effect on their ability to get full-time nurses at the hospital system. Has nothing to do with that, ladies and gentlemen. And you'll hear or see in the letters that have been submitted. We heard from the folks at the ACI and how difficult they've had with being able to get nurses there. With the enhanced nurse compact, they would be able to bring in nurses if they can't find nurses within the state of Rhode Island to do that. You're going to hear from the military families and how they support this, because as families move from state to state because of the fact that their orders where whoever, whether it's the husband or the wife that serves, the partner within that family who has that nursing license also needs to be able to move with their nursing license. So with that, I would ask you to seriously consider this legislation. This is good for the state of Rhode Island. It's good for the nurses in the state of Rhode Island. And I think moving forward, there should not be any loss of state revenue by virtue of going to this. This is good for patients and for those nurses who actually practice in the area of telemedicine and telenursing, which has been something that we have relied upon so much during this pandemic time. This will help those nurses as well. So I ask you to consider this. I think this is good for the state of Rhode Island.
Thank you, Speaker Pro Tem Kennedy. Do we have any questions? Yes, Representative Morgan.
Thank you, Chairwoman. And Representative Kennedy, I don't know if you have a title that I'm supposed to say.
Speaker Pro Tem.
All right, Speaker Pro Tem Kennedy. This is actually a really good piece of legislation. I just have one question.
Mm-hmm.
Is it more expensive for the nurses to get the multi-state licensure,
No. So,
to maintain it?
no, they're still going to have to go through continuing education like they normally would, but they would have the opportunity, if we approve this in the state of Rhode Island, to either continue with their existing license, which only applies to the state of Rhode Island, or they can get that enhanced license, which would allow them, if Rhode Island were to adopt this, then to be able to work in any of the 35 states that currently have this.
But it doesn't cost them?
It should not cost anything extra for them.
Okay, thank you.
Any other questions? Oh, yes. Sorry. Yes, Representative McLaughlin.
Chairman Kennedy, basically, in reference to the licenses themselves, okay, as you know, all hospitals who are accredited, the Department of Health actually issues all the licenses.
And just so you'll know, there was a letter from the Department of Health fully supportive of this legislation, because once again, this will allow them to permit a nurse, for example, if we have a shortage and they have to have a nurse come in from another state that already has this enhanced license and process, the Department of Health doesn't have to do anything extra because they've already got that license to do so.
That's great because, my wife being in a medical profession, believe it or not, Jaco will actually come in, and you know who I'm referring to, okay? And that's the one thing they check in hospitals, licenses being up to date, so on, so everything's all set there.
Absolutely.
Thank you, Chairman Kennedy.
Thank you. Anyone else? Okay, we'll move on to verbal testimony. First up is Donna Policastro from the American Nurses Association. Donna, this is...
Yes.
This is Vice Chair Susan Donovan from Health and Human Services Committee.
Good evening.
You're on.
Thank you. Thank you, everyone. Thank you, Vice Chair Donovan and members of the committee. I have been testifying on this bill, previously the Nurse Licensure Compact and then the Enhanced Nurse Licensure Compact since 2007 or 8. When the License Compact first passed in 2007 and 8, we had just had Hurricane Katrina. And the HEW and the Senate HHS committee at that time knew that it was time to be able to mobilize nurses. By the way, I am the executive director of the Rhode Island State Nurses Association, the professional association of registered nurses. And I think Representative Kennedy did an eloquent job of outlining why we need to have the compact back in the state. Just to let you know that the reason that we did not pass the enhanced compact, the only change between the original nurse licensure compact and the enhanced compact was that they added federal background checks. But lo and behold, we had already brought that legislation forth for nurses before this happened, and Rhode Island had already done that. I would use this analogy that it's very much like a driver's license. We all, nurses, take a national exam called NCLEX. We have a license in our state, a compact license, and we're allowed to go to Maine and New Hampshire, the closest compact states, and practice in those states if a need arises. There are many nurses in this state that have had barriers to their income. They work in the state of Rhode Island. However, because of telehealth and nursing education, they deliver either care via telehealth or they deliver online nursing education. But in order to do that, they have to be licensed in each state where their students or their patients are. So, for example, if I am a pre-op nurse at the Miriam Hospital and I have a patient coming in for surgery who lives in Seekonk, I can only read off to them the instructions for surgery, and if they ask me a question regarding their care, I cannot answer. That is a barrier to patient care. So I would hope in consideration that you would reconsider passing this bill. We had a pandemic. We had to mobilize nurses from other states to come in quickly. I am told by my colleagues at the Board of Nursing that they had to bring in temporary help in order to license those nurses. I've also heard anecdotally, well, it must have brought lots of money into the Department of Health. I am told that it did not, because it took so much overtime and many fees to the temporary agencies that, in fact, Rhode Island may have lost money to do this. It's a different era. It's the era of telehealth. It's an era of innovation. Rhode Island needs to catch up, and we need to pass this bill. Thank you, and I'll be glad to answer any questions.
Thank you, Donna. Any questions for Donna? Thank you, Donna, for your testimony.
Thank you.
Next up is Dr. Jocelyn Liasca from, okay. Dr.
Hi.
Liasca?
Yes, ma'am.
Hi, this is Vice Chair Donovan from Health and Human Services. We're ready for your
Hi,
testimony.
Vice Chair Donovan. Thank you so much for this hearing tonight. I am here tonight testifying in support of House 5194. I will try to be succinct, but I want to just give a little background so you know I'm a hometown girl. I hold a diploma from St. Joe's, a BSN, an MSN, and a practice doctorate as a DNP from URI. I am a quadruple board certified practitioner. I am board certified as an RN, a family nurse practitioner, a nurse educator, and a clinical nurse leader. About 50% of my time is spent providing direct care in my community in Rhode Island. I provide urgent and emergency care in my hometown. I also serve as the medical reservist with Rhode Island Disaster Management. In my other role, I teach for a university in another state in their online graduate nursing program, in a program that we don't offer in Rhode Island, which is why I teach out of state. It is a clinical nurse leader program. I also work per diem for a national telehealth provider in the provision of telehealth, primary care, and mental health care. Here's the critical point. When teaching or treating patients outside of Rhode Island, either role, I am required, because we are not compact state, to hold a license in each state where I have a student or patient. When I'm treating patients in my telehealth platform, I'm also required to hold my nurse practitioner license in each state as well as a DEA license wherever I'm prescribing. Currently, I have 15 different levels of licenses in 15 states, 16 including Rhode Island. And here's the most critical impact to Rhode Island nurses. Average licensure costs need to be broken down. The cost of a DEA license is $731. Licensure as an RN is $135. As a nurse practitioner is $145, plus my $200 for controlled substance registration. I need all 4 of those to practice in any one state. My fees in Rhode Island hover around $1,100 every 2 years. Multiplied times 15 states, I'm spending over $16,500 for my licenses every 2 years or so, depending on renewal cycles. The time involved in obtaining and maintaining these licenses and monitoring for fraudulent activity and meeting renewal deadlines is overwhelming. An error on my part could cost me an unnecessary and costly discipline by a local board of nursing in any of these states. At this point, I purchase FBI criminal background check fingerprints by the dozen when I'm up in Cranston, and we're all on a first-name basis. At least 50% of my graduate students are active duty military and spouses. They come from states across the country, and they live internationally where they have limited access to a remotely based higher educational program from reputable universities. In my telehealth practice, especially in the last 14 months, I have to decline patients if I don't hold a license in the state where they have called in from. Not having a license where students or patients reside results in a real decrease in access to safe, effective, quality health care or accredited, reputable, remotely based higher education. The data is explicitly clear from all states where multi-state compact licensure exists that this type of licensure does not increase the amount of travel nurse replacement or displacements of in-state nursing staff. And the proof of that is to simply open the Providence Journal jobs listing for registered nurses. You will be overwhelmed at the need. Rather, multi-state licensure improves the quality of life for Rhode Island nurses and patients at all levels and allows for fluid, safe, approved movement between states, which is well proven to increase access to health care and higher education opportunities to individuals from areas who lack the ability to access either. Multi-state licensure reduces the cost burden to systems by reducing multiple state licenses for employees, which are redundant, and they simply do not provide the same level of safety that one multi-state license with an accurate database can provide, because they don't talk to each other even electronically. So if there's a discipline in one state, it may take months to years before that discipline catches up to a nurse who is not in a multi-state licensure. I urge you to re-enter Rhode Island into the 21st century nurse licensing solution, and I thank you so much for your time tonight.
Thank you, Dr. Liasker. Are there any questions for this witness? Okay.
Can I add one more quick thought on the 5611?
Sure.
I just want to let you know, for those of us who have high deductible insurance plans, that bill is a critical bill because, for instance, my high deductible insurance plan is $3,000. If I'm not informed by the pharmacist that there's a lower cost option to a medication that's been ordered, I wouldn't know it. And up until $3,000, I have to pay cash. So for the high deductible plan for healthy individuals, and thankfully I am that, this is 5611 is an important bill. Thank you so much for indulging me. I appreciate it.
Thank you, Doctor. We'll go on.
Thank you.
We'll go on to the next caller, Lynn Blaze from the United Nurses and Allied Professionals. Hello, Lynn.
Yeah.
This is Vice Chair Donovan. You're testifying on Bill 5194. You can begin.
Yes, good evening. Thank you, Vice Chairman Donovan and members of the Health and Human Services Committee. I thank you for the opportunity to testify in opposition of House Bill 5194, the Nurse Licensure Compact. So as you know, I'm Lynn Blaze. I'm a registered nurse for over 36 years now in the state of Rhode Island. I'm a practicing recovery room nurse at Our Lady of Fatima Hospital, as well as the president of United Nurses and Allied Professionals, representing over 7,000 frontline healthcare workers in the state of Rhode Island. I think it's important to note, and related to this legislation, is we were a part of the compact state, and we left that compact in 2017. And I think with good reasons. I think we need to stop the participation and continue to be independent for transparency reasons. Knowing who is practicing in the state of Rhode Island is important. We need to do our own criminal background checks. We need to do the verifying of credentials. We need the control. We need to have the Department of Health and our Board of Nursing overseeing who is practicing in the state of Rhode Island. We need the local people to monitoring the continuing education, monitoring any disciplinary actions. We need the safety of knowing who is taking care of our patients and that those nurses are committed to the state of Rhode Island. And there is the financial impact. Our fees go directly into the state of Rhode Island, and I think that's an important part. A very important piece of the information is the state has shown it can process large numbers of license applications in a short period of time. We have seen it happen when Rhode Island Hospital went on strike a few years ago, and during the current pandemic, we've had no problem issuing emergency licenses for nurses to come into the state. And we know when we issue those licenses, those are safe nurses to take care of our patients. In closing, I think it's important to note that our surrounding states, Massachusetts, Connecticut, New York, and New Jersey on a limited basis do not belong to the compact, which negates the desired effect for many Rhode Island nurses. When Donna had mentioned about a nurse calling a patient in Seekonk, Massachusetts, that doesn't change with this law. Massachusetts does not belong to the compact state. Connecticut doesn't, where those are the places we do a lot of our telehealth kind of medicine. So once again, I respectfully ask that you vote no in opposition of this bill for the safety of the patients of Rhode Island. Thank you.
Thank you, Lynn. Are there any questions? Oh, yes, Representative Fogerty.
So are you telling me that you wouldn't take a background check from another state, or you wouldn't be able to look at the continuing education credits from, most of the time the continuation credits come from different magazines, different nursing journals, medical journals. the state wouldn't accept those as part of, tracking these patients, I think it would be easily turned in and could be followed up. I think when a background check from state to state is pretty much the same. So if you have a police department accrediting a person in one state, it should be really accepted in another state.
Right. The issue, Representative, is the Department of Health, the Board of Nursing, will not be looking at those things. As they said, it's like having a driver's license. You're going to come into the state with your driver's license, which is now your nursing license, and say, okay, I have my nursing license from X state, so I can come in and practice in Rhode Island, where no one in Rhode Island has really done their due diligence to validate that nurse license, their CEU programs, if there's any discipline records on those nurses. So a driver's license and a nursing license, it's not a fair comparison.
So, but if you're a Rhode Island nurse, you have to turn in your credits to the Department of Health, I would assume. And same thing with your background check. That couldn't be kept on another nurse who comes into the state of Rhode Island?
They would have to, I would assume, go through the Life Compact and request that information. It's not something that they would readily come in with. Right now, when that nurse applies for her license, she has to prove those pieces. With this legislation, they just come in with the license, and then it would be up to the state to then go back and validate that all the information is correct.
Could that be amended in this bill that would give them support? And, oh, it's in the bill. Oh, right. There are 11 things that have to file. That's what Representative Casey, Speaker Pro Tem Kennedy, is indicating that is in the bill. Sorry to give you a promotion.
Yeah, but I think it's more that the compact holds all of that information, and then it's up to the state to review that information.
Thank you.
Thank you, Lynn. Are there any other questions? Oh, Representative McLaughlin.
Yes, Lynn, this Representative McLaughlin, in reference to your concern, with the licensing and that, I'd like to ask, what is your hospital policy right now in reference to travelers? People that work temporarily in your hospitals.
Yes, at Fatima Hospital, we do have several travel nurses working in several different departments. But what that means is those travel nurses have had to apply and have an active Rhode Island license to be able to come in and work at the hospital. So that means that the Department of Health has been able to review their credentials and their background check before they issue them the Rhode Island license to work at our hospitals.
Thank you.
Any other questions? Okay, thank you, Lynn.
Thank you. Have a good night.
You too. We'll move on to Hannah Stern from ACLU, Rhode Island. Hannah, this is Vice Chair Donovan. You're testifying on Bill 5194.
I am. Thank you.
Okay.
Thank you, Madam Chair and members of the committee, for your time this evening. My name is Hannah Stern. I'm testifying on behalf of the ACLU of Rhode Island. Last session, the General Assembly passed really important legislation concerning fair chance licensing, which was implemented just to ensure that justice-involved individuals who are eminently qualified for their chosen positions are not disqualified from occupational licensure just because of their criminal record. We're concerned, however, that this legislation does not reference the critical protections contained within the statute, and this bill actually contains standards of determination for license eligibility, which immediately conflict with the fair chance licensing legislation. So we're ultimately concerned just that this legislation could possibly prevent an otherwise entirely qualified nurse from obtaining a license under this bill based on a criminal record, which our state law specifically notes is not automatically disqualifying. So just to ensure that there are not complications with this important and really critical law, which was put in place last session, we would encourage amendment to this bill to just bring it in compliance with the provisions of fair chance licensing. So thank you very much for your time. I'd be happy to take any questions.
Are there any questions for Hannah? Okay, thank you, Hannah, for your testimony.
Thank you.
We'll move on to Emmanuel Falk from SEIU New England. Emmanuel, this is Vice Chair Donovan. You're testifying on Bill 5194.
All right. Thank you, Vice Chair Donovan, Chairman Casey, and happy St. Patrick's Eve to the whole committee. This is Emmanuel Falk. I'm with District 1199 SEIU. We represent about 1,000 frontline RNs in the state. We are opposed to joining the nurse licensure compact, as we always have been. So when the original compact was originally passed in Rhode Island, it was not really a big problem in the beginning. In the early 2000s, we'd see more travelers come in during the summer, when there were a lot of vacation. But come 2010, 2011, 2012, what we saw, especially at women and infants, is it started to become part of the staffing pattern. It wasn't just people coming for a couple of weeks. And what the compact does is let's not kid ourselves, it makes it easier for travelers to come into Rhode Island. And there's a lot of quality studies about falls increasing with patients when you have more travelers. The team dynamics are completely thrown off, and oftentimes people are not trained. So some specialized nurse programs take 3 months, even longer. These travelers come in, they get an orientation for a day or two, and then they're doing the work on the units. It's a really big problem with our members in terms of the quality. A lot of horror stories. It does make it easier for nurses that have been disciplined in their home states for a bunch of issues. Maybe not disciplined to the point where they lost their license, but disciplined enough where it's hard for them to get in a job. I'm not saying that there are definitely good travelers and solid RNs that travel state to state, but we think this makes it easier for more and more travelers to do the work. I mentioned that it's become part of the staffing pattern we've seen more and more. That is depriving new nurses opportunities to get real good full-time jobs. Salve, RIC, URI, CCRI, it is depriving them of opportunities. And if, what we have learned in the pandemic is that we have a nurse shortage. We really need to build our nurse workforce, and we need to do it locally. So a couple of, I'll just wrap up very quick. Sorry, Vice Chair. As there were a lot of states listed, as it was mentioned by my sister Lynn, Mass and Connecticut are not in the compact. 2 states that are, Mississippi and Texas, states that have pretty much gotten rid of their mask requirements. So I would like to ask the committee, just rhetorically, do we really want to make it easier from people from Mississippi and Texas to come into our hospitals with all the different variants out there? I do want to say one last thing, and I'm sorry I'm going over my time, but the military spouse issue, it's a good issue. That could be a really easy standalone bill. Representative Bennett introduced it a few years ago. There could be legislation passed to just direct the Department of Health to have reciprocity for military spouses. So thank you for your time, and happy to take any questions.
Yeah. Are there any questions? Yes, Representative Fogerty.
Emmanuel, I can understand your point with the nurses and the nurses union, but some of these nurses could come out and be part of a pact, even our nurses who are trained here, RIC or URI, and then, could go to other states and go to work too. So, or people who came here, nurses who came here from other states to go to school can get licensed in their own state and then come back to Rhode Island. I mean, it just seems like it'd be an open opportunity. I'm not worried about, you're going to have bad nurses. Sure. I'm not saying they're all going to come flocking here to Rhode Island, but I think with this pandemic, we did need more nurses, and who knows what's down the line. So I just want to try to be open with it. And I'll say that my sister is an 800 nurse for Aetna Insurance. She's on the call-in line. She's the only nurse in Aetna because she's out of Connecticut. She called all 50 states and now is licensed in all 50 states. So I went through this kind of with her, listening to her. It took her over a year to do it. And that's why I think we need this cross coverage from state to state, because, everybody doesn't stay in one state and we can't be so provincial. I think it's better to think wider than that. So, if we do have another health issue, we can do this. And by the way, Rhode Island was the hottest state for her to get her licensure in out of the 50 states. So believe me, that's why I heard it from her.
Right. I believe that has been streamlined. I'm not going to pretend to know about your sister's situation. We do have hundreds of nurses that work at Women, Infants, and Butler that work in Massachusetts. They get their Rhode Island license. I'm not saying it's the easiest license to get, but I don't think it's that onerous. It's moved online. And it really does deprive locally trained nurses of job opportunities. We've seen it on the front lines with the staffing pattern, not just having travelers come in for a few days or a week or two in the summer, that they're there year round now. And this will make it easier for more travelers to come in the state. So I totally respect your position, but I would like to also point out the American Nurses Association, I believe, is against that. That's the largest association of the nurses in the country, and that is not a union association.
Thank you, Emmanuel.
Thank
Are
you,
there any more
Emmanuel.
questions? Thank you for your testimony.
Thank you.
The next caller is Christopher Arnold from the U.S. Office of Defense.
I totally respect your position, but I would like to also point out...
Mr. Arnold, could you turn off your device?
Yes, Madam Vice Chair.
Okay, thank you. You may
Sorry,
proceed.
Madam Vice Chair, honorable members of the House Health and Human Services Committee, the Department of Defense is grateful for the opportunity to support the policies reflected in House Bill 5194, the Nurse Licensure Compact, or NLC. I am Christopher Arnold, the Northeast Region Liaison at the United States Department of Defense State Liaison Office, operating under the direction of the Undersecretary of Defense for Personnel and Readiness. In last year's letter to the former governor accompanying the Secretary of Defense report on military spouse licensure, the department noted that we see Rhode Island as having taken several important steps toward improving licensure for military spouses. Notably, we see interstate compacts for occupational licensure as an excellent method of assisting all practitioners in addition to providing reciprocity for military spouses. House Bill H5194 seeks to address such recommendation through the long-term solution of the NLC. The secretaries of the military departments have made the importance of military spouse licensure explicitly clear as they consider the availability of license reciprocity when evaluating future basing decisions or mission alternatives. This consideration was codified by Congress as a requirement in the 2020 National Defense Authorization Act. Notably, Section 2883 sub H requires future basing decisions to be evaluated annually on whether a state has entered into licensing compact and has a standalone approach. Traveling nurses can be licensed in Rhode Island without a compact, yet occupational licensure has been an enduring problem for military spouses. Obtaining a license in a new state can be both time-consuming and expensive. The department encourages states to engage in immediate actions to fully implement military spouse licensure laws, near-term actions to attain a baseline of getting a military spouse a license within 30 days based on minimal documentation, and long-term solution through compact. Common misinformation about compacts is that they either lower or raise the standards for the occupation, when in fact, compact states have the option to issue a compact license and also a state-only license to maintain their state's standards. States have committed to using interstate compacts, which establish common understanding of competency and its measurement within the occupation, to resolve the interstate issue of license portability. One such example is the NLC, which allows an active duty service member or their spouse to designate a home state where the individual has a current license in good standing. The NLC, now active in 34 states, allows nurses to obtain multi-state licenses to practice in 35 states, saving them from the cost of having to apply for an additional license in each state. In nearby Pennsylvania, the State Nurses Association had originally been opposed to the Commonwealth joining the NLC, but after 6 years now supports joining the compact as, quote, reservations initially expressed by some groups such as significant lost revenue to the State Board of Nursing or public safety concerns, have not materialized. Ocean State military nurses and military spouse nurses must needlessly bear the time-consuming and costly expense of applying for single-state licensure in every state where they seek to work. There has never been a credible study that the NLC, or for that matter, any licensing compact, reduces job opportunities or diminishes quality of care. In fact, implementation of 7 compacts in 42 states has proven exactly the opposite of those specious arguments. On behalf of the Department of Defense, to support the NLC is to support the servicemen and women of our armed forces and their families. In closing, we are grateful for the tremendous efforts that Rhode Island has historically made to support our service members and their families. We appreciate the opportunity to support these policies, and we are especially grateful to Speaker Pro Tem Kennedy for introducing this critical legislation to rejoin the NLC. Thank you.
Are there any questions for Mr. Arnold? Thank you, Mr. Arnold, for your testimony.
Thank you so much, Madam Vice Chair.
Representative Bennett, you are on the list to testify.
Thank you. I want to talk to you as a nurse, not as a representative. The nursing situation in every state in the country was tough during the pandemic. And because of the pandemic, we weren't allowed to cross borders. Because of the spreading factor. My American Nurses Association, which is the main mode of the nurses in our country, does not support this, does not support the compact. If we have an emergency, the governor has the power to open our borders. We don't need a compact to do that. And the reason I oppose this bill is because of our local, hardworking nurses who take care of us, our families. They don't want to travel. They have a family. You know, and if you want to travel, you can go to New Hampshire, join the compact, and travel. But we do not need outside nurses coming into the state. We have excellent colleges. We have Rhode Island College, URI, Salve Regina, and CCRI, all producing nurses. A lot of those nurses don't want to travel. You know, they may come here to go to school, and then they go back to their own state. It's important that we look at the people that take care of us. If I'm getting ready to retire soon, and I'm a full-time nurse. When I retire, what's to stop the hospital to say, well, we're going to go part-time. We get rid of the benefits, don't have to pay no benefits. We get 2 part-time nurses from out of state, and it eliminates us paying benefits. There's other factors that you bring in traveling nurses or compact nurses. They don't know where anything is. When you ask for something, they don't know. A major part of nursing is team. I have to depend on my team. You know, I'm a psychiatric nurse, so I really have to depend on my team. And if I got somebody in there that is just there to make money, you know, to be here in the summertime when our beaches are open, whatever the reason is they want to be here, they're not invested or committed to Rhode Island. They're invested and committed to their own traveling. You know, and that's what this whole thing's about, is traveling. They want to tell you, oh, telemedicine. We do most of our telemedicine with Connecticut, Massachusetts, New York, and they're not in the compact. And you got to ask yourself, why aren't they in the compact? Because they want their own independence. They don't want to get in this. It would even change it would go to their commission instead of the Board of Licensing. We asked the nursing board licensing for statistics probably 6 years ago, and we never got them. And every year they brought this bill in front of us, and we've asked for the statistics showing that this is needed. They've never given them. I think we have to stand behind our nurses. You know, I don't want to travel. I got a family. You know, I'm happy right here in Rhode Island. I've worked in the same hospital for 20 years. Before that, I worked at Kent County for 10 years. And then I worked for surgeons for another 18. I love Rhode Island. And I don't want to see people coming in from out of Rhode Island, taking jobs from brand new nurses coming in, you know, who don't want to be part of that compact. And I think it's a matter of choice. If you want to join the compact, then go and join it in another state. Like they said earlier, nurses in Texas and Mississippi right now don't have to wear masks. Now with the compact, they could come here, and you don't know what they're bringing with them, you know. And like I said, the governor can open the borders up anytime we have a major problem. Right now, it wouldn't have worked because every state had a major problem with nurses. Every state. The compact wouldn't have helped. You know, we would have still been in the same boat. So I hope you oppose this. It's not needed. It's somebody's going to make money off of it, and it's not going to be the Rhode Island nurses. And, you know, and you've had both unions come in and oppose this. You're going to be. That's a good way to bust the union too. Bring in compact nurses to bust the union. You know I don't want to work with non-union. If you look at what unions have done for us, they give us a 40-hour week. They gave us benefits. They gave us better pay. They gave us better opportunities for work. And to bust the unions, we go right back to being at the mercy of big money. And these are things you have to think of. A lot of times in nursing, if you're questioned on something you've done wrong, they'll ask you to resign. They won't want to pursue you. They don't want to spend that money. They don't want the embarrassment. They'll ask you to resign. And then when you resign, you go to another state that doesn't, you know, part of the compact would be perfect for you because you can move about. I think we got to support our local nurses, and you know, and I hope you do too. I mean, they're the ones that are doing it right now. So that's all I got to say. I'll take any questions if anybody has any.
Any questions for Representative Bennett? Representative Speakman.
Thank you, Vice Chair. This may be for Nurse Bennett, or it may be for the sponsor. Do you know, and if Speaker Pro Tem Kennedy covered this and I missed it, I apologize. Why did Rhode Island leave the compact in 2017? And why aren't Massachusetts and Connecticut in the compact? Do you know?
Oh, they don't want to be. They want their independence. They want the right to do what we do for our own nurses. I mean, I don't want an Idaho nurse coming in and telling me this is the way we do it in Idaho. Well, I really don't care the way you do it in Idaho. I care about the way we do it in Rhode Island. You know, our rules. You know, it's like I said, it's a team. When you work with the same nurses 40 hours a week, you get to know them really well and they get to know you. And when they're tired, you step it up, and when you're tired, they step it up. The reason Mass and Connecticut and Rhode Island's not in it is because it don't work for us. We don't need that kind of nursing. I didn't catch the rest of your comment.
I think Speaker Pro Tem is...
Yes,
yeah.
so thank you.
Thank you.
So what had happened with the state of Rhode Island was when the enhanced compact was first proposed, obviously, as you have already heard, the nurses' unions all came forward saying, this is a jobs protection bill. We need to protect our nurses in the state of Rhode Island. Once again, it has nothing to do with busting the nurse unions here, has nothing to do with that. But because of the opposition that came forth from the SEIU as well as UNAP, the legislation was never able to move forward. It was introduced, it was never able to move forward. As far as Massachusetts goes, legislation has been filed in Massachusetts this year. They have it as bill number SD 671. So it has been filed in the state, or in the Commonwealth of Massachusetts this year. Neither Massachusetts or Connecticut ever were part of the original compact. I will say, until the enhanced compact was adopted back in the late 2018, any Rhode Island nurse at that point had the ability to have that transportability. At that point, there were just 25 states that were members, but that Rhode Island nurse, and we heard from one of those nurses who spoke earlier on the phone, now she has to go through all of these states individually to get a license. And up until 2018, that was not a requirement. Once the enhanced compact took place, Rhode Island, for all intents and purposes, because we were only signatories to the original compact, it went away. The original compact no longer exists, and that's basically what had happened in the state of Rhode Island.
Thank you, that's helpful, thanks.
I disagree with that. The reason let me think now. The reason that Connecticut and Massachusetts, the reason they have the bill in front of them now is because they run it in these states every year. I've been opposing this bill since 2007. Oh, well, 2010, when I first came in. They're going to keep trying until they get in. Somebody's going to make money off of it. And it's probably going to be the agencies that hire the nurses that run them in different states. You know, and Rhode Island's a pretty nice state to come to, you know, if that's what you're into. I worry about the nurse that's got 3, 4 kids and a husband, or somebody like me who's got grandchildren, and I want to be around. I don't want to be traveling around. You know, I want to be committed to Rhode Island, have roots in Rhode Island, and take care of Rhode Island people, but I'll take care of anybody that comes into our state. I think that, you know, it's time that we take care of our own, you know, and that's been a problem with a lot of businesses, is that they're going to outside help. Instead of training a nurse in a particular field, they can just go to the compact, grab one, and bring them in. Why don't they train that Rhode Island nurse? You know, it saves them money, so they don't put the time in. I know I'm taking up a lot of time, and I will stop there, but please keep in mind that our Rhode Island nurses are some of the best in the country. So our schools are some of the best in the country. We really don't need other states coming in here that have different, like, restrictions. The pandemic's a perfect example, you know? The mask things, who wears masks, what their laws are. Rhode Island's pretty tight, and I think we're getting better. But I mean, I have to fight for my fellow nurses, and that's it.
Thank you, Representative Bennett.
Excuse me.
That ends the verbal testimony. We have written, I'm sorry, Representative Morgan.
Thank you, Chairman. This is for the sponsor.
Yes.
Yes, Speaker Pro Tem Kennedy, let me take this off. Do you have any data in those states that do have this compact on how many nurses actually take advantage of coming in and using it? I mean, is this, you know, where 50% of the nurses are coming from another state, or is it just, you know, enhanced mobility for nurses?
The answer is I do not have any specific data. I assume we could probably get that from the Nursing Compact organization. But I think, as you just stated, it's more of the enhancement of their license so that if they are needed to travel to another state, they're not coming here to vacation in the summertime and to use our beaches. If they're coming to Rhode Island, it's because there's a need for them here in the state of Rhode Island, or in one of these other states that are already members of the compact. That is essentially it. But, as was also pointed out, if it's Chairwoman Fogerty's relative who needs, for her job, to be able to do things within 50 states because Aetna, you know, has facilities in all 50 of those states. The fact that she has to spend a year of her life trying to get this a license in each of those states, when by the passage of legislation such as this, she would have the ability to have a license in already 35 of those states because of the ability to utilize that. So it really is something that is important. And then, as I previously pointed out, for the purposes of the telemedicine, we know CVS, for example, utilizes more and more the assistance of nurses in order to provide the health care within their particular facilities. And much more of that is now being done via telemedicine. But once again, to be limited to only being able to do that service in the state of Rhode Island makes it very difficult for that individual, when passage of this would enable that nurse to be able to operate in 35 states. That is one of the most important things. Again, it is nothing. There is nothing about this legislation that is there to take away jobs at the hospitals. This is not a bill that has anything to do with the Lifespan Network or any of the other hospital systems in the state of Rhode Island. It is simply to make life easier for nurses. And, you know, I would not disparage if somebody is able to go and get their degree in nursing, whether it's in Mississippi, Texas, South Dakota, North Dakota, or any other state. If they spend the time to get that license and they meet the requirements as set forth within this compact legislation, that means they're a nurse.
Yeah. again, I actually really support this bill, but I'm just wondering if the data would give us a better picture of when nurses do travel to another state, what they're used for. Is it for emergencies? Is it for telemedicine?
I think it's more for the emergency type of situation where, this past summer where the Department of Health had to really ramp things up in order to get nurses from other states approved here because of the fact we don't have that compact in place. But what I will do is reach out to the nurse licensure compact and try to get some additional information which I can get back to the committee members.
Okay, thank you.
Thank you, Speaker Pro Tem Kennedy. Any other questions? No? Oh, yes. Representative Kasar.
Okay, thank you, Madam Vice Chair. Speaker Pro Tem, thank you for introducing this bill. It's very interesting, and I understand the complexity. Having been on the operations side of a clinical setting and had gaps in availability of nursing, I see this as an opportunity to help the stability of organizations, of clinical services. Is there any data about sort of the trade-off? To me, it seems that without the opportunity for the traveling staff, that there would be mandatory overtime questions or potential overtime issues. Is that something that has been addressed here? Do you know, in any of the compact states, are we seeing less overtime or mandatory overtime?
As far as I know, I haven't heard of that issue as coming up, but again, that's another type of issue that I can ask the nurse licensure compact if they have any data on that type of information. Because obviously, some of the states that we're looking at here, some of them are very large. For example, Florida. I can imagine that with the number of hospitals in the state of Florida, that something like that may have come up at some point. So what I can do is inquire about that.
Okay. Thank you. Yeah, and I agree with you. I think that the integrity of people who go through nursing programs is the integrity of Rhode Islanders and the integrity of nurses in any other state. I think we're looking at the same thing. So I think there's an opportunity here. There's probably some details to be worked out, but it seems like we should consider that, especially if we are passing telehealth bill. We're going to see this challenge more and more. And telehealth is intended to make healthcare a bit more convenient, and it makes it less convenient if you end up having to juggle who a provider can talk to and who they can't. Thank you.
Thank you.
Representative Bia?
Yes, Representative Kennedy, do you have any data to show or explain to a committee in regards to is there like is there an hourly rate data between like where traveling nurses are compared to nurses in Rhode Island?
That, once again, my guess is that, a nurse that comes into Rhode Island would probably be paid some type of hourly rate, whatever that happens to be. I don't know if they're guaranteed a minimum number of hours or what the case may be. So that will be something I'll also ask that question.
Yes, please, because I think, I'm very open-minded on this issue right now. I'm listening also where Representative Bennett, also the argument, also from Rhode Island, also looking through these things. Also, we also sometimes have to look at our own Rhode Island resident also. So those are some of the data I'd probably like to see exactly if they're going to probably go that route in regards to hiring a traveling nurse at a cheaper rate as compared to people that reside in Rhode Island. So those are some of the data I would like to see.
That, as I said, I will be very happy to look that information up. Yep.
Chairman Kennedy, can you hear me?
Yes.
Okay. Don't need the damn mic. In reference to, I might be able to answer some questions. The travelers for lifespan, unlike, the compact, believe it or not, they don't have health benefits.
What, they don't have what, please?
When they sign on, they don't have health benefits. I can only speak for lifespan.
Yeah.
And I believe they do get some other bonuses, in reference to, housing and so on and so forth. But, I can attest to that fact that the travelers that,
Well, keep in mind, Representative McLaughlin, any traveler nurse that comes into the state of Rhode Island today is not a compact nurse in the state of Rhode Island. They must go through
Exactly.
to get their license in the state of Rhode Island, so.
But the hospitals do, actually, there's a savings there because they don't have to pay benefits, in reference to the travelers. They sign a contract for 18 months or whatever, 12 months, and that's it, Thank you.
Thank you, Representative Kennedy.
Thank you.
That ends the verbal testimony. We have written testimony submitted in favor of this bill by James Carney of Rhode Island APA, David Belasco of Lifespan,
David, my friend.
Dr. Alexander Scott from the Rhode Island Department of Health, the National Association of Government Employees, Patricia Coyne-Faig from the Department of Corrections, Jordan Goyette. The ACLU Rhode Island has no position, and the SEIU Healthcare submitted testimony against it. So that ends the testimony for Bill 5194. Next up is Bill 5369 by Representative Alzate.
Thank you, Chairwoman and members of the committee. So this bill comes to me, as many of you know, my boyfriend is now a veteran, and for like 2 years we've been talking about getting a dog, and it got really expensive when we were looking at them, and ultimately we ended up getting one. But this bill comes to me from him because he was talking about how much he missed our dog while he was away. And so what this bill will do is would waive the adoption fee to adopt a dog or cat from a public animal shelter for a veteran that presents a current and valid driver's license or ID card with the word veteran printed on it. So I like this bill because it just gives our veterans what I like to call a peace of mind, giving them, we all know how if some of us who own a cat or a dog, how meaningful they are to us. They're a part of our family. I love mine dearly, and they love us back unconditionally. They're so loyal, and to be able to provide something this small to a veteran who has sacrificed so much is just a really small price to not pay, if you will, in order to bring them some peace of mind. So I will take any questions.
Yes, are there any questions for Representative Alzate? Thank you, Representative.
I just think it's a great bill.
No.
I just think it's a great bill. I think veterans definitely deserve, and a lot of them who've seen action for PTSD, I'm not saying that's what your boyfriend's going through, but just the stress and strain, I think it's a beautiful, beautiful idea. Thank you.
Thank you. Any more questions? Thank you, Representative Alzate. That ends the testimony on Bill 5369. The next bill is Bill 5707 by Representative McEntee. Hello, Representative McEntee.
Hello, Vice Chairwoman. How are you? And members of the committee. So I'm here on House Bill 5707, which I was asked to put in last year, and then I put it in again this year, by the Pharmacists Association. So what this bill does is it removes barriers to treatment created by telehealth reform. It expands patient access to treatment. It improves adherence to therapy and continuum of care, and it reduces the stigma for patients. So over 40 states allow pharmacists to administer long-acting injectable medications. And allowing pharmacists to administer these medications can provide numerous health benefits. They increase access to care, it improves adherence to therapy, and it increases the quality of care and access to knowledgeable providers. This bill is supported by the pharmacists. It's supported by Joey Lindbeck, who is I think she sent a letter in for the pharmaceutical companies. But I believe with the pandemic, which is mentioned in a lot of the paperwork that I read on this, that the telehealth has been expanded in Rhode Island during COVID-19 pandemic, and permanent expansion is currently under review by this General Assembly. And it's been incredibly helpful for patients and providers during the pandemic. So I think it would certainly serve for those persons, especially with substance use disorders. Now, one of the things about the injections is that for patients suffering from the substance use disorders, the medication-assisted treatment is considered the gold standard in treating opioid use disorder. And that by getting the injection versus taking a pill, the patients have had more success. So with all of that in mind, I would urge that we give this very careful consideration and approve this bill. Now, I would like to also comment that Lenny Lopes, as we all know Lenny, he is not in support. He just wants a minor amendment. He represents the state's Veterinarian Association, and he believes we could resolve this on page 5, line 4. After the word profession, he thinks it's a good place to put the disclaimer. He basically wants to say that this does not apply to veterinarian medical assistants. That's fine. I have no problem with that. So with that amendment, I think we'll be okay. If anybody has any questions, I'd be happy to answer them, but I know we have a couple of witnesses. I believe the Pharmaceutical Association is, not the pharmaceutical, yeah, the Pharmacists Association is speaking on this. So any questions?
Yes, Representative McEntee or Chairman McEntee, did Ms. Lembeck submit any written testimony?
She said she was going to.
Okay.
So I don't know if it's in there or not.
Okay.
I don't think she's going to verbally testify.
We don't have it right now.
Okay.
We'll expect it.
Okay. Thank you very much, Chairman and Madam Vice Chair,
Are there any questions for Rep. McEntee?
and members of the committee.
Okay.
Thank you.
All right, we'll go on to verbal testimony. We have Leonard Lopes from the Rhode Island Veterinary Medical Association on the line. Mr. Lopes? Mr. Lopes? Mr. Lopes? Mr. Lopes? No?
Yes, good evening.
Hi, this is Vice Chair Donovan. You're testifying on Bill 5707.
Yes, that's correct. Thank you, Madam Chairwoman and members of the committee. Leonard Lopes on behalf of the Rhode Island Veterinary Medical Association, a group of more than 200 dedicated veterinarians who give their lives to the welfare of our animals. I want to also thank Representative McEntee for discussing this bill with me. We just have some technical concerns with the bill, and I also look forward to talking to my old colleague and friend Joey Lindbeck, who worked for me in the Department of Attorney General, as we straighten out some of the language and address some of my concerns. So with that, I will close my testimony.
Thank you, Mr. Lopes. Are there any questions for this witness? Okay, thank you.
Thank you.
that seems to be all the verbal testimony we have. We have written testimony submitted by Shatterproof, Courtney Hunter in favor, Dr. Alexander Scott from the Rhode Island Department of Health in favor, and MHARI, Lori Marie Pizzicata in favor. So that concludes the testimony on House Bill 5707. We're moving on to House Bill 5607, and Chairman Serper.
We're gonna go to Rep. Cardillo.
Oh, Rep. Cardillo, okay. 5607 by Rep. Cardillo. Where is he?
You're right up.
Okay. Good evening, Chairman, members of the committee. What this bill does, would waive referrals requirement to see healthcare specialists under certain conditions. Number one, under retirement, death or incapacity or loss of license, relocation of out of state, or practice, or dependent treating this is for dependent treating the healthcare specialist. Or when a subscriber or dependent has an ongoing relationship with a healthcare specialist for a pre-existing condition, notwithstanding any gap of treatment required, imposed by the policy, plan, or contract, insurance company. Number three, or whenever a subscriber or dependent without a primary care requires a referral from, say, a specialist from a hospital emergency room or an emergency care facility. This is just for referrals. And what it does, I believe after a number of years, you have a specialist and that you go to, and then after a number of years, you afford them the condition that feels allowed. I believe it's insurance providers, you have to get a referral to, or just go back to get a referral from your primary doctor, because if you have to go back to your primary doctor, you have to make an appointment, you got to pay a copay, he's got to take time out of his business. Another client who really needs his services, where you need the specialist, not his. And really, that's about it. That's what this bill is. It's only for a referral for a pre-existing condition.
Are there any questions for Representative Cardillo? Thank you, Representative.
Thank you. Thank you, Chairman, members of the committee.
There is one written testimony submitted by Jordan Goyette in favor of this bill. And that ends the testimony on 5607. Okay. Next bill up is 5704 by Representative Chairman Serpa, rather. I gotta get used to that.
I'm here, thank you. Thank you, Mr. Chairman and Madam Vice Chair. This is actually a bill that we heard last year, excuse me, and it was sent to a study commission, excuse me, that I chaired. We had probably 4 or 5 meetings. The final work project is in the process of being completed. In fact, we're waiting to somehow gather everybody who was on the study commission. We're waiting for the final report. And I think you have people signed up to testify, Chairman. So as best as I can understand it, well, I'll let you explain, but this bill has been heard, and we're waiting for the final report, so we can present it to the study commission, and then we will maybe look at some sub-As, if necessary.
Thank you, Chairwoman. Yes, we do have, there is a study commission that we just recently extended the dates
Right.
for, so that they can present their findings prior to us making any decisions. And once they do present their findings, we're actually going to hear this bill again. So everybody that signed up to testify, I will, if they would like to speak briefly on this, I will allow that. But what we're going to do is, I want to let everybody know that's listening and expecting to testify that once we get the findings of the study commission, this bill will be reheard again so that we have all the facts, everything that we need to do to make a proper decision regarding this legislation.
Thank you, Chairman.
So I will go ahead, if there are any questions for Representative Serpa, we'll take them now from the committee. And if not, I'm just going to go right to the verbal testimony. Who do we have? Okay. Thank you, Mr. Pavzillo. Hello, Rich.
yes.
Richard, how are you
Yes.
today?
I am doing great. I'm doing great. How are you doing?
Good, sir. I don't know if you were able to hear my most recent statement, but regarding this bill, we do have a study commission that we just extended the dates for. They're going to be presenting their findings hopefully over the next month at some point. And after those findings, we're going to rehear this testimony, rehear this entire bill again. So I will allow you to comment briefly. Go right ahead, but I don't want you to extend it too much because obviously we're going to do this again.
Great, great. Well, I'll do a consolidated version for about a minute here. So I'm Rich Pazillo. I'm the Executive Director of the New England Hemophilia Association. I stand tonight with 22 other patient groups who submitted a letter today that proudly support HB 5704. Hemophilia, if you're not aware, is a genetic condition that only affects about 20,000 people in the U.S. We do not have a generic option for treatment. Our annual cost is about $350,000 per year, which we know is undeniably expensive. But patients don't set or control these prices, and subjecting patients to step therapy puts us at risk. It is not effective or appropriate way to manage this class of patients for a number of reasons. I will hold all those reasons, but ultimately patients get hurt, and the protections around a safety measure to protect against step therapy really put patients like those living with hemophilia in a transparent way so that they can have access to their treatment. So with that, I will turn it back over to you and just urge you to continue to advance this important bill to protect Rhode Islanders living with the chronic condition.
Thank you for your testimony, Richard. Are there any questions at this point from the committee? If not, okay, we're going to move right along. Thank you, Richard.
Great, thanks.
Hello, Mr. Goldberg.
Yes, sir.
Yes, sir. How are you today?
Good.
Very good. I hope you had heard my initial announcement that we do have study commission findings that will be forthcoming, and we will be rehearing this bill in its entirety at some point in the near future. If you would like to testify, I'd like you to just keep it down to a minute quick, and we'll move right along. Go right ahead.
Mr. Chairman, I'm on this bill, opposing this bill on behalf of CVS, and let me tell you, in 30 years of lobbying, I can take a hint, and I'll save my testimony for the subsequent hearing. Thank you very much.
Okay, so you are in opposition?
Yes, on
Okay.
behalf of CVS.
Okay, thank you very much, sir, and we will speak soon.
Thank you.
Hello, Ms. Chandler. This is Representative Casey, Chairman of the Health and Human Services Committee. How are you today?
Hi, I'm well, thanks. How are you?
Very good, very good. We have you here on 5704. I do want to let you know that the Step Therapy Study Commission has been extended, and they will be giving us their findings soon. If you could keep your testimony on this bill to just a minute or two, I would appreciate it.
Absolutely. So thank you so much for the opportunity to provide testimony. I really appreciate that. My name is Corey Chandler. So I'm the Government Relations Director here in Rhode Island for the American Cancer Society Cancer Action Network. As many of you probably already know, ACSCAN supports evidence-based policy and legislative solutions designed to eliminate cancer as a major health problem. So we are here in support of this bill. ACSCAN did serve on the Step Therapy Commission that has, like you mentioned, yet to present recommendations. So my testimony tonight is in line with the recommendations for the committee. So I'll just quickly highlight 3 points and leave out the details. So I just want to make it known that this bill, it would ensure that treatment is based on clinical guidelines and not financial benefits. It just establishes a basic framework for when it is medically appropriate to exempt patients from step therapy and implement step therapy programs that are based on clinical guidelines that are developed by independent experts, which is critically important to cancer patients. But I'll explain those. I'll hold the explanation on those reasons. And then secondly, this step therapy can cause delays in accessing the best course of treatment. So this bill would actually just institute timelines that insurers would be required to follow. So 24 hours for non-emergency situations and a response received within 72 hours in other cases. And lastly, it's just critical to note that this is not a bill to prohibit insurers from using step therapy. It just simply seeks to balance cost containment with patient needs. It's legislation that's actually been enacted. Similar legislation has actually been enacted in over 20 states, so there's really no reason to believe that it would result in increased costs. But I'll leave it at that, and I'm happy to come back and testify after we presented our recommendations in the commission.
Thank you very much, Corey. We appreciate your testimony. Any questions from the committee?
Thank you so much.
Okay, we're going to move on to our next witness. Okay. Hello, Mr. Marshall. Robert, are you with me? Oh. Hello, Mr. Marshall.
Hello, how are you?
I'm good, sir. How are you? This is Representative Casey.
I heard your announcement. I'll be very short.
Thank you.
And we will mostly save our testimony for the final bill, but I am here on behalf of the Rhode Island Developmental Disabilities Council. We've been testifying this bill for quite some time. We do think that it affects the quality of life of people that have severe medical needs, especially severe seizure disorders. And we just want to see the step. We understand the insurance companies need to try things, but we want to make sure that we don't jeopardize quality of life in the process. So we will save our comments for the final bill.
Thank you, Robert. We appreciate that. Are there any questions for Robert? Okay, before we move on, I just want to let you know at this point that we have received multiple written testimony from many people. We are going to list them briefly for the record. The Epilepsy Foundation of New England is in favor. American College of Rheumatology is in favor. American Cancer Society is in favor. The Arthritis Foundation is in favor. Aimed Alliance, Stacy Worthy is in favor. Hasbro Children's Hospital, Dr. Jason Shapiro is in favor. Susan G. Komen is in favor. National Psoriasis is in favor. AAD is in favor. The New England Hemophilia Association is in favor. Mr. Terry Martesian of the American Health Insurance Plan is against, and the Providence firefighters are in favor of this bill. That is all we have for testimony. Are there any questions from the committee before I close this hearing? Again, we'll be doing this again in the near future once we get the results of the study commission. Hearing none, I will close the hearing on House Bill 5704, and we will move on to Representative McGaugh. Representative McGaugh, are you with us?
I am here. Thank you so much.
Thank you. Representative McGaugh, you have a bill, House Bill number 5463 regarding medical insurance coverage for epinephrine injectors. You have the floor. Go right ahead.
Yes, thank you so much, Chair, and thank you to the committee. I'm going to keep this short. I know that you all have a lot of bills to listen to tonight, but I do think this is an important piece of legislation. Anaphylaxis is a life-threatening allergic condition. It presents with symptoms such as difficulty breathing, hives, swelling, rapid heart rate, low blood pressure, and those things come on very quickly, and they have to be treated urgently. If left untreated, an anaphylactic reaction can result in an emergency room visit, hospitalization, or even death. Anaphylactic reactions they're attributed to an estimated 1,500 fatalities per year in the U.S. So in order to treat that, we have to treat them quickly with something like epinephrine. The average price of an EpiPen right now is it's approaching $700 for a 2-pack of epinephrine. There are generics available, but the average price even of a generic is close to $400 for a 2-pack. And that's incredibly limiting to someone with a limited income. For patients who have a high deductible plan, or a patient with a high co-insurance where they have to pay a percentage of the cost, this could be a significant barrier to having them have access to the life-saving medication that they need to have available to them to keep them out of the emergency room or worse. And so what this bill does is just requires that health insurance plans in Rhode Island cover EpiPen with a $0 copay so that we can ensure that everyone who has a potential for a life-threatening allergic reaction has access to the medication when they need it immediately. And that's all I have. I'll take questions.
Thank you, Representative McGaugh. We have some questions from the committee, if you'll stand by. Representative Ackerman, go ahead.
I just want to make a comment. I love this bill. As someone who carries EpiPens everywhere I go, I know how expensive they are. And you do have to change them up every so often, and every time I go to make a copay, it's a huge amount, even with the health insurance. So thank you very much for this.
Thank you, Representative Ackerman. Are there any comments or questions from the committee at this time? Thank you, Representative McGaugh. We have no more questions. We appreciate your testimony. Do you have any final comments before we close the hearing?
I do not. I just want to thank you, Representative Ackerman. Thank you for your support.
Okay. That concludes the testimony for House Bill 5463. We're going to move on. Representative Baginski, you are here with us on the WebEx meeting. Are you there?
I'm here, Chairman. Thank you.
Okay, Representative Baginski, you have 3 bills before us today. I will allow you the leeway to take them in whichever order you prefer.
Thank you. We'll zip through them all.
Okay.
We'll start with House Bill 5710, Uniform Controlled Substances Act.
Okay.
This bill is, I'm sorry?
Go right ahead.
Oh, thank you. This bill is a companion bill to a Senate bill sponsored by Senator Fogerty, and it originates from large medical practices that want to have more oversight over prescription drugs, particularly opiates, being prescribed to patients, sometimes by multiple providers in the office. So the bill is a little bit long and it seems complicated, but in essence what it does is it gives the medical director of any medical practice access to the prescription drug database to make sure that patients are not being overprescribed or misprescribed opiates. The Department of Health is in support of this. Our fearless leader, Dr. Scott, has submitted written testimony in support, and I'm happy to take any questions. If you'd like, I can move on and save all the questions to the end. You tell me.
Stand by for one moment, Representative Baginski. What I'd like to do is just announce on this particular bill, Dr. Alexander Scott and the Rhode Island of the Rhode Island Department of Health and the Rhode Island Medical Society are in favor of this. They have written testimony. What I'm going to do, Representative Baginski, if you would indulge me, I found out there was one person that needs to be called for testimony on the last bill, and I'm just going to handle that before we move on, so we keep everything kind of in line, okay?
Happily.
All right, just stand by with us, and we're going to make a phone call to one of the witnesses for the previous bill. This is Representative Serpa's bill regarding step therapy. Please, right away.
No problem.
Okay. Okay, this is great. I know exactly why. She's actually on our list. Okay, so I'm going to quickly reopen 5704. We're going to speak with Ebony Morris, I believe. Hello, Ebony?
Yes,
Hello, this is Representative Casey, Chairman of the Health and Human Services Committee. How are you?
good. How are you?
Okay, now, judging by your area code, I believe you're somewhere in the Washington DC area?
Yes, I'm in Maryland, Central Maryland.
Okay, we have a transposition of area codes. You are 410, Rhode Island is 401, so we had an issue with that. I completely apologize, and I'd just like you to go ahead with your testimony. I don't know if you were able to hear it, but because the Step Therapy Study Commission has we've just extended the dates for them. They're going to be giving their findings regarding step therapy shortly, and then we're also going to rehear this bill again, so we will have you back for testimony, but I'd like to give you some leeway and go ahead and give your testimony.
Sure, I did hear that, so I can be pretty brief since you guys are still going through the process and may hear some similar themes. Just a couple of things that I just wanted to highlight is that the legislation, we're obviously in support of the legislation, but it does not mandate any coverage or change of benefits that insurers seek to implement. It does not require or does not prevent, I should say, insurers from requiring patients to try any equivalent generic drug, and it does not conflict with existing generic substitution laws. Additionally, most states, which you may see in your final report, have not seen a heavy fiscal note or impact with the legislation. There has been no evidence to support the claim that step therapy reform contributes to increases in insurance premiums. We can provide you at another time with some of the data that we have that shows the case that there has been no difference in insurance premium trends for states that have passed step therapy reform in the last several years. If there's anything else, any other questions I could answer, I'd be happy to.
Thank you very much for your testimony. Just for the record, Ebony, your last name, is it Mora or Morris?
Morris, M-O-R-R-I-S.
M-O-R-R-I-S.
Yes.
Okay. Thank you very much, Ebony. Are there any questions at this time for our witness? Thank you very much, Ebony. I know we're going to hear from you at another time as well, so we look forward to seeing you then.
All right, thank you.
Thank you. That will close the hearing on House Bill 5704 again.